Good afternoon, everyone. This is Jeff Smith, and welcome to today's webinar, Taking a Patient's History by Dr. Wayne Carr. I'd like to welcome you all this afternoon and glad to have you online. If you have any questions as Dr. Carr is going through the presentation, you are all on mute, so you can just type your questions into the chat box on the right-hand side of your screen, and we will address those possibly as he's going through the slides. If not, we will do it at the end. So just or as we begin, a couple things. First of all, the disclaimer is that we are not speaking for Medicare, Railroad Medicare, or any other governmental or federal licensing or disciplinary agencies or any other agencies. We have taken information from Medicare, Railroad Medicare, and other sources and have put together this information. And the information has come from a number of different sources, including but not limited to Noridian as well as CMS. So we know, and many of you have seen this information a number of times, but we know that there are audits currently being done of chiropractors. For instance, we know that Railroad Medicare has been auditing chiropractors for the last number of years, and they continue to see a high error rate. And especially with Railroad Medicare, we know that the top denial reasons include failing to have a adequate treatment plan, and if there is a treatment plan, that it lacks objective measures to evaluate the treatment effectiveness. And then also we know that in the 2015 OIG work plan that chiropractors are again included in the plan. And we know that the main things that the OIG is looking at as it relates to chiropractors is maintenance therapy as well as documentation. And so that's where you come in as a staff person, that it's really important for you to be gathering the important information, the relevant information from the patient, so that you can help the doctor meet the requirements of not only properly documenting the care, but helping to diagnose and understand what the condition is that the patient has presented with. So with that, I'm going to turn it over to Dr. Carr. And again, if you have questions, type them into the chat box, and we will address them as we go. With that, Dr. Carr.
Thank you, Jeff. Welcome, everybody, and I hope that you get a lot out of this hour and are prepared to do a better history on the patients this afternoon. So as we know in our initial visits with patients, and really with all patient visits, there are four aspects to the treatment plan or the evaluation, and they are the history, the examination, diagnosis, and then the treatment plan. And what we're going to focus most of our attention today is on our history, and this is the most important part of the initial visit. With the history, we should be able to determine a definite group of diagnoses that the condition could be, and then when we go in with the examination, then we kind of finalize our thoughts. But the history is a valuable aspect of the initial visit and should definitely put us in a direction where we can finalize the diagnosis with the examination or with some advanced studies. So we're going to talk about the history on a new patient. This could be a new injury or just a patient that has not been in the office for a while. So it starts always with what is the chief complaint. So simply ask the question, what are you here for? What is your main complaint today? As I go through this, there may be secondary complaints or even tertiary complaints. If there are those, then if there's a first and a secondary, then you would probably go through this whole process. If it becomes more and more, it might be one of those situations where you're going to say, well, let's just put that aside for today and we'll talk about that more next time, because you don't have time to do that. Or let the doctor know they're also complaining of their large toe hurting, and they said they stubbed it against the bed. And then he can decide from there where he needs to go. But focus on, at least the first and secondary, and then if there is time, you can look into the other ones. So after the chief complaint, and just a brief statement of the chief complaint is low back pain, neck pain, arm pain. That's all you really need to do, knee pain. That's what the chief complaint is. Then you go into the mnemonic, and we'll go through the letters of that. And starting with L, where is the location of pain? Again, it doesn't have to be a long statement, just where is the location. Then mechanism of injury onset. So what did they do to hurt themselves, or was there something that did that? Now, oftentimes, patients don't remember that when you're in the room, and they remember when the doctor's in the room, or they may remember at the next visit or half of the visit into the treatment. That's very common to have that. But again, just try to ask them what's going on, and that creates them thinking, and later on they usually come up with the, oh yeah, I remember this, or I remember 2 days before that. The next thing is N, which is nature of the pain. So is it a sharp pain, a dull pain, throbbing, whatever? You want to try to get a little bit of the nature of the pain. We know that if somebody says they feel like they have a knife in their back, then that points us to that it's a joint problem in the back. Burning, tingling, those things are important for us to know if there's maybe a nerve involved. O, onset. When did the injury occur? Again, a simple statement, or when did it come on? And even if it's something that they don't remember an injury, you need to get down a date or a reference of a week or a week and a half ago they started noticing the pain. P, palliative or provocative. Okay, that's really important. We don't see that enough in doctors' notes, but what makes the problem better? What makes the problem worse? That's going to give us a really good idea of what's going on with the patient, and also gives us a good idea of working on their goals, and we'll talk about that more later. And then P also is past history. Have you had this problem before? Again, a very important thing to know. We want to know if they've had it before, and then we can ask the questions of what did they do for it, what was the were there imaging studies done? We can learn a great deal if we just ask a simple question, have you had this before? Q is quantity and quality. That's your VAS scales and your outcome assessment scales. If any of you do PQRS, the measure 131 is the pain assessment. So we need to ask that VAS every visit, but especially on that first visit. And it's good. You can do a VAS scale of how they're feeling right now, what's the worst pain they have, what's the average pain they have, and what's the best they feel. That gives us a lot of good information, because if we just ask them that, what's your pain, and they say, well, it's a 2, but then at times it's a 7. I mean, that's valuable information for the doctor. It's valuable information in the documentation to support the need for care. And it's a lot harder to get rid of a 2 and a 1 pain than it is to get rid of a 7 pain, because that's going to decrease, and that's going to show that the care is beneficial. So simple questions of, what's your pain today? What is it at its worst? What at its best and average? And those are simple things that you can document down. When we first greet patients, don't focus on just the pain. Greet them as a person first, and focus on better. If you see, hi, it's nice to see you today, and then, focus on the fact if you saw them the day before, and you go, oh, you're walking much better. It looks like you're getting along much better. And then divulge into the information of, what is the pain scales and stuff like that. But treat them as a human being before we treat them as a number. Or find out the numbers. We never want to treat them as a number. As far as the outcome measures, if you're using those in their office, there's various ones. I would definitely encourage you to use them. They're great value to coming up with a treatment plan, goals, and also helping with the diagnosis, and also ultimately getting paid for our services. But functional outcomes just tell us how the patient is doing through their tasks, through normal daily activities, and it definitely gives us good information. Concerning outcomes, we can also look at outcomes of just the question of, what is it that you can't do now that you would like to do or could do before this injury? I can't walk greater than 5 minutes. I can't stand greater than a minute. I can't get out of a chair without assistance. I'm limping, or I can't do the laundry anymore. Simple things like that. Those are, again, are good for goal setting, which we'll talk about in just a little bit. So as we continue with the mnemonic, we're at R. So radiation referral. Does the pain radiate? Does it refer somewhere? Again, just a quick statement of yes, yes, it refers, and where does it go to? And try to be a little specific. If it's in the arm, what thing does it go to the hand, and what fingers, or where does it go to? That gives us, if it's a certain nerve in the neck or lower back, by them telling us exactly where it goes, gives us a good indication of which nerve is involved and which spinal level would be involved. As the symptoms, other symptoms related to the pain, this is where, are they having any problems with urination? Are they having any abdominal problems? Are they having headaches, nausea, vomiting? Those are things that you can ask there related to their problem. T, temporal, again, time. When is better? When is the problem better? When is it worse? Is it bad at night? Does it wake you up at night? Very important questions that we'll talk about later too, and put some more emphasis on that. And what have you been doing for it? Have you seen anybody else? Have you been icing, heating, taking any medication? So the answer to that is always, or the question after they tell you that is, does it help? Does it make any difference? Is it short term? Is it long term? Because if it is helping, we want them to continue that. If it's not, we want to switch to something else. And then also ask if there's been any previous diagnostic studies, or have you seen anybody or anything like that, so we know we can get that information or learn from what they've learned from that too. And then what? What is your occupation? Very important to know what they do. If they're having neck and upper back pain and they're working at a desk all day, we want to be able to help educate them on proper ways to sit. If they're lifting all the time, anything like that, it's very important. And if you don't understand their work, ask what their physical activities are at work. Has your work changed because of the complaint? Have your daily activities changed because of the complaint? And learn from that. And at the end of every interview with the patient or patient history, ask them, is there anything else we have not discussed that you would like to tell me related to this condition or your general health? So quick summarize, we're using the mnemonic after the chief complaint, LMNOP, QRSTU, VW, and that should give you that history. Now, I've been warned by the doctors already that I can't have you doing a history that's longer than 6 minutes in some of your clinics. So you need to be, very efficient doing this process, but you also want to do a complete job. And if you feel that it's just something that's going to take you a little bit longer, it's a good idea to maybe inform the doctor that it is going to be. And you also need to be in control of the interview with the patient. We oftentimes are with patients that want to talk a lot, which is good, and most studies show that doctors cut off their patients within seconds of them explaining something. So allow the patient to give you the history, listen to them, and if it's somebody that's going to spend a lot of time talking on something, and you're planning on doing the vitals, maybe start doing the vitals while they're talking and try to multitask a little bit, but constantly listen to what they're telling you. And if it gets to be where you're having to document that, type it a lot, maybe just stop typing it, just kind of speed up the history process, and then maybe finish that after you're out of the room or at the end of the interview. And everything is solved by communication. So just communicating with your doctor. If it is going to take a little extra time, take that time to inform them about that. And sometimes the receptionist will know that somebody talks a lot. It's going to take a little extra time. Have them come a little earlier and stuff like that. But get a good history. I can't emphasize that enough, that we need to get a better history, and it really will point us in the right direction of a quality diagnosis and treatment plan. So in addition to the history, and many times this is just on our intake forms, family history, and this is if it's pertinent. You may have this on a previous visit if it's a new problem or something like that, so you don't have to do that on everybody. But take the time to look at the intake form. If they're filling out an intake form in your office, look at the intake form, and you can get a lot of information out there that you don't necessarily have to ask, or you need to just clarify it a little bit, and it's already there. Past health history, again, of the chief complaint is important. You may have already got that information, but their general health, their prior illnesses, their surgical history, and things like that, and if they've been to a chiropractor before. Again, that may be on the intake form. If it's not, there's simple questions to ask and valuable information. Prior chiropractic care is an important question because you want to know how they responded, how they were treated, and if they're maybe leaving another chiropractor's office and coming to yours, what was the decision to leave that office. Those are good things to learn so that you can better manage that patient. The review of systems are an important part of ruling out red flags that, again, we'll talk about later. There are many forms that do review of systems, and you have them on your intake forms. But this website just has a list of different symptoms related to the various systems of our body, and it's important just to ask those things. I mean, if somebody's coming in with headache, you want to know if there's problems with anything with the head, nausea, or anything like that. If they're having thoracic pain and chest pain, you want to know about regular heartbeats, chest pain related to exertion and things like that, difficulty breathing. People with lower back pain, you want to know if they're having abdominal problems, are they having urinary problems, and things like that. So a lot of these are on intake forms and not necessarily through questions. Or if you have an EHR, those systems are also available to you that will help you get through a review of systems quite easily. Again, your history, and if we do an EHR, we all know that medication and dosages are part of that, allergies to medication, and also airborne allergies, and the social history. Those are all important things to have in our documentation. Again, most likely on your intake forms or somewhere in through there. So to summarize with our history, again, we want to know the chief complaint if they have secondary complaints, and then with each of those complaints, we want to efficiently go through the mnemonic L through W. And if you want to just write that down somewhere so you can reference that all the time, or just the letters written down, it's pretty easy to, if you start doing that, you'll remember that mnemonic, and it will become second nature to you. And oftentimes I'll just kind of go through it in my head and make sure I got all of those. And then if I don't have all that information yet, I will ask that final question. But again, what we want to come out with that history is a good indication of what the doctor feels the condition may be, so he can zone in on his examination, and especially on his any X-ray or special studies that may need to be ordered. He has a good indication of where he wants to go, and the exam will just help him through that. And we'll touch more on that in just a little bit. As we move through the physical exam, I know many offices have their staff do the vitals on the patient, and again, during that vital process, it's a good idea, if the patient is a talker, you can kind of start doing that as they're talking and listening to them. And remember, listening is a valuable tool, and oftentimes what our patients need, and somebody that just understands their complaint rather than anything else. So we want to make sure we're listening, both the staff and the doctor. And then the second thing on the physical exam is the observation. That's something that oftentimes the doctor can't see when you go up to the front of the office to bring the patient back to the room. You see how they get out of the chair. You see how they walk. All those things are important, and I would definitely document those. If you don't document those, at least tell the doctor that they had a lot of trouble getting out of the chair, they're limping. And on future visits, again, document that they, were able to get out of the chair easier, were able to walk back better. Those are important things to know that we want to make sure that the treatment we're providing our patients is beneficial. So those are important things to prove it. If they're not getting better, then we need to change it. We need to help them learn ways that they can modify that behavior. And lastly is to get paid for our services, showing that it is beneficial. So we need to make sure we're documenting that type of information. Okay, we're going to take you through a couple questions here, and you will go into a survey with these. So there's a poll that's open on your screen, and just take a minute to read the question and then answer the question, and then we'll move on to the next one. And on this one, we have a 65-year-old female that presents with 2-month duration lower back pain with unexplained weight loss of 30 pounds over the past year. We're just waiting for a few more to vote on this. We will not know your scores, so don't feel intimidated by the question. Okay, you have 10 seconds left. We're still waiting for a few of you. Okay, the next question. Okay. Okay, we're going to share the results here first to the first question. 64% said malignancy, 18% infection, 18% spinal fracture. Okay, we'll go over those when we're done with all the questions. Okay, the next question is a 15-year-old male with severe knee pain with night sweats. What are you thinking? So go ahead and answer the question for this. Okay, we had a more confident group that time. 100% said infection. Okay, the next question is a 75-year-old female with acute middle back pain after riding a car and hit a bump and jarred her back. Okay, what are you thinking? Okay, on this one we had 10% say malignancy and 90% say spinal fracture. Okay, the last question is a 40-year-old male presents with acute lower back pain, unable to hold urine, obtain an erection, and has numbness between his rectum and genitals. What are you thinking? Okay, we have 11% say malignancy, 11% say infection, and 78% say cauda equina syndrome. All right, so as we go to the answers there, the first question was the 65-year-old female that presents with 2 months duration lower back pain, unexplained weight loss of 30 pounds over the past year. The answer to that is malignancy. Now, the one thing that I will tell you that some people that have pain and are losing weight, it may be an intended weight loss, so it's important to ask that question. But even if it is intended, we still want to probably raise a red flag here. But some people also just are hypochondriacs, where they think that everything is a tumor, and other people are really, think, oh, it's nothing, it's just this, and the weight loss has nothing to do with it. And I've seen both of those in my office. So we need to make sure, if somebody is losing weight that's unexplained and has back pain, don't hesitate with further evaluation on that. The second one was the 15-year-old male with severe knee pain and night sweats. Night sweats definitely point you off to the direction of an infection. The 75-year-old with acute middle back pain after riding and bumped her back, we're thinking spinal fracture there, but as some of you said, malignancy. It could be due to a pathological fracture too of a weakened bone, so that's another good answer with that. And even you could think maybe infection with possibly a weakening of the bone, but mostly we're thinking a compression fracture. And then the last presentation was the 40-year-old male with acute lower back pain, unable to hold an erection and numbness between the rectum and groin. That's a cauda equina syndrome, and that's when a disc herniation is severe enough to put pressure back into the cauda equina, which is the nerves that leave the spinal cord in the lower part of the lumbar spine and into the sacrum. Now, basically, the answers that you got on that question, you guys did very well answering the questions. That's not necessarily, your responsibility to catch that, but it'd sure be nice that if you have an indication or a thought of that when you come out of the room, that sharing it with the doctor who may be busy at the time, not able to focus quite as well. It'd be nice for you to say, I found this in the history, and maybe be aware of that. Secondly, you can see that less than 2 lines of a history provided us with the diagnosis on these patients. So we can learn a great deal from the history. We didn't have to do an examination on any of those patients at that time to at least narrow the diagnosis down. So again, it shows how important the history is. But what we looked at on those patients are red flags. And the red flags that we want to rule out on everybody are malignancy or cancer. And those have pain worse at night, the weight loss. You could have some chills, fever, night sweats, but mostly you're looking at the pain, worse at night, not relieved by laying down, and weight loss. The infection, again, they got chills, fever, night sweats. They may be compromised hosts. They could have AIDS or something like that. They could have IV use, previous UTI or a skin infection or some local infection going on. Spinal fractures, again, trauma and osteoporosis, and maybe the malignancy would do that. The cauda equina, the saddle anesthesia, which is numbness between the rectum and the genitals, and then incontinence of urine, failure to hold erection, those things are going to show up on there. And then different arthropathies are something we want to look at, and if it's something else like an abdominal aneurysm. Besides each of those numbers, you can see the percentage of how often those are occurring in our office, but they do occur. So we have to make sure we're looking for those. We've all had those in our offices, and we have to be on alert to look for those things. These are red flags. These are stop, refer out, send for diagnostic studies. The cauda equina syndrome is an emergency situation. You want to get them to a surgeon as soon as possible. So we don't want to miss those. Another thing that's really in the press and talked a lot about with chiropractic care is strokes. And most of the research is pointing to that the chiropractic care does not cause a stroke. The stroke is occurring when the patient comes into our office. And I know we've seen this several times in our office, and I'm sure you have too. So we want to spot the stroke and get them to the emergency room as soon as possible. So there's different things you can look at. Fast is a good way to look at it too. Look at the face drooping, arm weakness, or speech difficulty. So that's one mnemonic you can use. You can also use STR, which are the first three letters of stroke, and it's asks the patient to smile, asks them to talk, asks them to raise both arms over the head, and then there's a new sign, stick your tongue out. So those are simple things you can do for somebody that is having some facial pain and headaches, and you can oftentimes notice that just looking at them. If they're having trouble smiling, if they're having trouble talking, if they can't raise their hand or stick their tongue out, they're most likely having a stroke, and that's a patient we do not want to treat. We want to get them to the emergency room as soon as possible, both for mostly for the patient, but also for your liability. Okay, we have another case presentation here, and we have a 45-year-old female that presents telling that she sued the last doctor she saw for sexual advancements. Think about, think about what you would tell your doctor, if that was somebody that came into your office. And a 55-year-old male presents saying the past chiropractor was too rough. Is that important to share with your doctor? So what these are yellow flags. Okay, these are proceed with caution. And those are, as we just talked about before, adverse reactions to treatments. We want to know that. We want to maybe modify their treatment in some respect. A disc herniation, pregnancy, mild osteoporosis, vertigo, dizziness, hypermobility, and psychological with that too. Now in this case, we talked about the sexual advancements, and we're not saying that the patient failed to tell you that, but or lied about the sexual advancements and sued them. But the situation is that they're going to have some psychological issues being in a room alone with the doctor. So you want to make sure that you talk to the doctor about that, and most likely he's going to ask you to come in the room with him, which would make him more comfortable and the patient more comfortable. But also there's situations where people have psychological issues where it could be litigation issue or other things going on, and those are yellow flags that we want to be aware of. And then the 55-year-old with the adverse reaction to similar treatments is definitely something we want to be aware of and learn from our history. So I'm just going to touch a little bit about some of the documentation that you may help your doctor with and helping him prepare his notes. But we want to develop treatment plans for all our patients. And our treatment plans should include our duration and frequency of care, in addition to the time we're going to reevaluate them. And it's important that our treatment plans transition from passive to active care. And why I tell you that is the fact that patients are going to complain to you about doing their exercises, and it's important that you encourage them to be an active participant in their care. And as the bottom says, we must empower our patients to be an active participant in the management of their pain and disability. They need active care, whether it's home exercises, just walking around and that stuff. We need to get them active as much as possible. We don't want to increase their pain. We don't want to make their pain, say, the VAS scale, looking at that. We don't want to increase their pain. It'd be best to have them exercising in a 0 to 2 VAS scale, but you could get them up to a 5 if they can tolerate that. But we need to get them active, and it's important that you encourage that to the patient too. Self-care instructions, many of the self-care instructions you guys should be giving the patients. I mean, they know, you may use a form and the doctor could circle it, you could go over it with the patient, but oftentimes you guys understand things, and you can go in there and talk to the patient about how they could be more comfortable with their knee or whatever. Those are good things that you can assist the doctor with, including lifestyle modifications. And then, getting further into it, preventative screening too is an important part of seeing the patients. We're oftentimes the primary doctor of our patients, and we need to be the ones encouraging that. And then focusing on goal setting. As we did through the history, we did the functional assessments, and we asked them, what are they doing now that they can't, or what can they not do that they were doing before? What do they want to be able to do? That's where goals start. Goals start with what their goals are. It's not what your goals are for the patient. So that's a good question to ask. And if you have that information available to the doctor, then you can quickly, easily make goals for that condition. So a great question to ask is, what are your goals with the care here? And sometimes it's like pulling teeth to get a good answer out of them. I mean, they're going to say, I just want to feel better. But just being more specific, because then you can modify your treatment program based on their goals, and also know when they maybe met their goals and they're happy with their goals, and you could release them. I mean, we sometimes think that people want to come here and be totally pain-free and never have pain again. Many times they understand that I'm going to have pain. I would just like to be able to go to the grocery store and do my shopping and come home and be able to complete that task. And goals need to be smart. As we're making goals for our patients, we need to be smart, which means they need to be specific, measurable, achievable, relevant, and timed. And those things cannot be achieved with us trying to make goals for somebody, especially with relevance. So we want to make sure we're talking to the patients about goals. So ask us for specific. Okay, what is it specifically that you want to do, such as distance able to walk, difficulty driving. Again, we talked about going to the store. Measurable, you could measure by time, the VAS scale, by distance, things like that. Achievable, is it possible that the patient could do that? I mean, somebody that comes to your office that's had 10 years of low back pain, to put that the goal is for no low back pain is not realistic. So you want to have something that's achievable, relevant, and important to the patient. Don't forget that item. It has to be important to the patient, or they're not going to try to follow through. And then time. How long are we talking about? It may be a short-term goal of a month, or a long-term goal of maybe 6 months to a year. Not that they'd have to be in your office, but with a home exercise program. So poorly constructed goals would be to increase sitting endurance, to improve driving, to increase function, reduce pain. Those are all just very poor. There's no way to really measure that. We want to create SMART goals. So well-constructed SMART goals are increase sitting endurance at the desk from 15 minutes, hold on just a second, from 5 minutes to 15 minutes within 1 week. Decrease difficulty driving. They have 8 to 10 pain when they're driving. Decrease it to 5 to 10. To return to modified work duties for 3 hours per day within 3 weeks. Those are good goals. That's what companies want to see when they read your notes, and they're easy to come up with. They don't have to be overly long. Now, pain can be a goal in somebody's very acute, or I'll ask people, what is your pain limiting your ability to do? And they'll say, I can do everything. It's just that I have pain with everything. Well, then our goal is going to be to reduce the pain with daily activities from an 8 to a 4. You're not going to get from an 8 to a 0 in 2 weeks or a month, unless it's something they've never had before, which is possible. But focus on pain is fine if it's something like that, but you really want to get to something functional, and the doctor can add some of his exam findings into there. And then when we're going to assess the goals, and especially talking Medicare, if our goal is to allow the patient to sit to stand, their current level is an 8, and we want to reduce it to a 3 on the VAS scale, then we want to ask that every time. How much pain are you having getting up and down? And if that's what our goal is, we need to assess that every visit. And then once the goals are met, it's definitely appropriate to advance the goals into something more specific to the patient if that's what they want. Again, it's what they want, not what you want. And there could be some discussion on the fact that you could, we could probably do better than that, but they may not have the time or the resources to get to there. Okay, so now the patient's coming back to our office for future visits. Again, we talked about the first one about their goals and just talking about their goals all the time. We want to quickly review their chief complaint, and if there's any, if somebody came in with urination problems or nausea or stuff like that, we want to review that quickly. How do they feel that they've done since the last visit? And maybe some of the things that that you knew from before they were having trouble with. Ask them those questions, and then assess that towards the goals. It doesn't have to be a long visit. And again, start that visit with a friendly, warm, hello, nice to see you today, and then asking them, are you better, worse, or the same? I know we do that all the time, but focus more on better. I mean, 90% of the reason people come to any healthcare provider is stress related, and a lot of stuff is mental. So we want to get them thinking positively, being optimistic rather than being pessimistic. So focus on the better, not the worse. And then our examination will include our physical exam, our assessment, and then us documenting our treatment plan. And anything that you can help your doctor that he would like assistance with that is valuable. And on the physical exam part of your notes, definitely document what you see in the patient, that they're, maybe in better spirits, walking better, all those things, or did not appear to be in as acute a pain today. And our daily notes consist typically of a SOAP note, a subjective, objective assessment and plan or procedures. And we want to make sure that we're doing a nice daily SOAP note. If you're doing computerized notes, you have to be careful that the cloning of the notes doesn't say the same thing from one visit to the other. We need to use our computer systems wisely, not as a crutch. And then lastly, if you're writing your notes, they have to be legible. Somebody has to be able to read them. The documentation the doctor provides to other doctors, to insurance companies, to the government, that's the only window a lot of people have into your practice. So you decide what that window you want that window to look like by the documentation that you do. And just quickly with Medicare, that can be sometimes a stickler with what we're doing, but we have to make sure that we're demonstrating that they have a significant health problem. Pain is not just enough. And we want to make sure that what we're doing for them and what we're finding, of course, to the spine for Medicare is a direct relationship to what the problem the patient is having, and the treatment will provide a direct relationship to get it better, and that there's a reasonable expectation that the patient will get better. All care must show medical necessity. This is for all insurances. And it also must show that it's beneficial. Someone may need something, acute lower back pain, but if they're not any better in 4 weeks of care, then the care is not beneficial. The doctor needs to change the treatment program. He needs to refer out or do some diagnostic studies. And that's not untypical to have them not better in a period of time. But we just need to make sure we're changing that, or we're sending out for further evaluation. And all of your doctors do that. But that's why it's so important that our documentation shows that, because if we're going to somebody's going to look at that chart and see that they're not changing over a 4-week period, and they're going to pull the patient from you, deny care, and all those things, and just create headaches for all of you. So if anybody has any questions at all, we can answer those now. You can just type them into the question area. The goal with office notes and taking the history is always a challenge. But we're striving in our office to get to an A on our office notes, and every office needs to look at striving to get that A. Will it be an A on every single patient and every time they come in? Maybe not, but it's definitely something we need to strive for, and definitely we want to make sure that we're staying above a C on a grade and not get to a F. And as Jeff showed you some of those statistics early on Railroad Medicare, many doctors don't even send their notes in when they're asked, because the notes would not do the job that they need to do, and also the doctor maybe not even be doing notes. So we want to make sure we're getting all that done on every visit. So if any of you have any challenges that you want to share with us today, or if you want to email Jeff, you can definitely do that. I know that there was a lot of information. You have the slides. It's pretty self-explanatory that you can just read that over and learn from that. And anytime you have any questions, or after you talk to your doctor, if you have some questions, don't hesitate to email Jeff and we'll get back to you. The history is very important, which translates to your job being very important. As we did in those case studies that we went through with one line, you were able to come up with a diagnosis. So I can't emphasize enough how important your job is in helping our patients get the correct diagnosis and the right treatment program. So keep striving to get better. If you ever come, read articles that talk about taking a proper history. And then what I would encourage you to do is enjoy the process of being a detective to come up with the diagnosis. When you're done with them, write down on a piece of paper what you thought the diagnosis was, and then after the doctor's done with them, go in and look at the notes or ask the doctor, what was the diagnosis of that patient, and learn from that. And you can become an expert in coming up with those things, and your doctor would love it if you come out and say, they have this problem, and I think it's a cervical radiculopathy. I think it's a gluteal tendinopathy. And don't just do it on things that you're interested in. Do it with everything, and I think you'll enjoy that a little bit more, and you'll continue to do better with that. So I appreciate you guys taking the time to learn. I look forward to seeing some of the great histories that you guys are doing in your office, and I'm sure your doctors will be thrilled with how good you're doing with them. And again, if you have any questions ever, just email Jeff, or your doctor can email Jeff, and we can definitely answer those.
All right. Well, thanks, Dr. Carr, for that great presentation. And again, as he said, if you guys have any questions after you get a chance to digest this information, feel free to send me an email, and I can pass that along to Dr. Carr. Just as a reminder, to receive your CE credit as a CA, what you need to do is complete a 6-question quiz, which I will be sending you by email when we get done here. And then once you take the quiz, I'll see the results and send you the results back. And a reminder, you need to achieve a score of 75% or better in order to get the CE credit. So that you should be receiving that here in the next few minutes. And again, if you have any questions later on, feel free to either email me or give me a call. So with that, thank you again for participating, and go out and do a great job with your patients. Have a good afternoon.